So lung cancer detection and can CT help? And in the course of the last few years, there's been some important developments in terms of increased lung cancer screening by CT, and I'm going to go over some of those things and also just talk in general about lung cancer screening, what to expect if you undergo screening, and a little bit more about lung cancer screening and outcomes. So a preview of the lecture, I'm going to do a little brief background on lung cancer, some epidemiology, sort of to justify why lung cancer screening is so important to detect cancers at an earlier and more curable stage. Some of the risk factors for developing lung cancer. What is a screening test? Not just lung cancer screening, but what is a screening test in general? Also screening for lung cancer with just a regular chest x-ray versus a chest CT. Who are the appropriate candidates for screening? And if you are an appropriate candidate for lung cancer screening, how do you get screened, and what should you expect when you go in for screening? So as most people know, lung cancer is the leading cancer-related cause of death for both men and women. And lung cancer deaths are greater than those for breast, prostate, and colon cancers combined. So it's a really, really significant disease. As most people are aware, cigarette smoking is the leading risk factor for developing lung cancers and is linked to between 85 and 90% of all lung cancer-related deaths. But it's important to realize that non-smokers can also develop lung cancer. The link between tobacco abuse and lung cancer was first reported by the Surgeon General in 1964, and sort of around that time or a few years after, the overall consumption of cigarettes started to decrease. And I've got a little graph that shows us that in a few slides. There are other risk factors for developing lung cancer, not just cigarette smoking. We see a lot of commercials on television regarding patients with asbestos-related lung disease and lung cancers related to asbestos exposure. So asbestos exposure certainly is a risk factor for developing lung cancer. Also, elevated levels of radon gas. So people hear about radon gas in their basements. So elevated levels and increased exposure to radon gas has been linked to development of lung cancer. Very important, we don't want to discount this, is secondhand smoke. So somebody who's not a smoker but is getting secondhand smoke from somebody who is a smoker. And also just a family history, somebody else in your family, a first-degree relative who developed lung cancer, puts you at an increased risk of developing lung cancer yourself. So here's a little graph that was taken from online that shows us the estimated number of new cases. This is for 2013 in men and women, both greater than 110,000 for both men and women, new cases of lung cancer diagnosed in 2013. More cases diagnosed of breast cancer in females and prostate cancers and cancer in males. But the estimated number of deaths related to lung cancer is higher than both prostate and breast. So it's a more fatal disease. The survival expectancy is diminished as compared to breast and lung cancer. So I talked about the Surgeon General announcing the link between tobacco abuse and lung cancer in 1964, and this is the per capita consumption of tobacco products over time. So if we drop a line down to 1964, cigarette smoking and other forms of tobacco abuse were sort of at their peak at that time. And after that link was announced, that sort of started to fall off, and thankfully that's continuing to decline. It took a little bit longer for the peak of deaths related to lung cancer in both men and women to peak. It just shows you that the exposure to cigarettes and other forms of tobacco, the development of lung cancer is not instantaneous. It takes time for those carcinogenic effects to eventually develop lung cancer. But thankfully those rates have started to decline as well, and hopefully they'll continue to decline. So a smoking history, what's a significant smoking history? So we're going to talk about the current recommendations for patients who should be screened with CT for lung cancer. But currently a significant smoking history is considered a 30-pack year or greater history of smoking. What's a 30-pack year smoking history? That's a pack per day for 30 years, or half a pack per day for 60 years, or 2 packs a day for 15 years. So the equivalent of smoking 1 pack per day for 30 years. If you smoke more, that amount of time can be less. Current recommendations also for patients who should be screened. Patients who are currently smoking, or those who quit within the last 15 years, in addition to that 30-pack year smoking history threshold, and also ages 55 to 79. So patients younger than 55 do not currently fall within the screening guidelines, nor do patients who are greater than 79 years old. If there are other risk factors that we talked about before, a family history of asbestos exposure, then that age falls from 55 down to 50, and the threshold of 30 pack years goes down to 20 pack years. It's important to remember that there's no safe amount of smoking despite these guidelines. You can't say, well, I only smoked 25 pack years, so I'm not supposed to be screened, so I'm safe from developing lung cancer. There is no safe amount of smoking, so even occasional or social smokers are at some elevated risk of developing lung cancer. We talked a little bit about secondhand smoke. It's very dangerous, especially for kids. We all know that New York City banned smoking in restaurants and bars some number of years ago. And a lot of apartment buildings in the city are starting to ban smoking, so we have these smoke-free buildings. So even if you have appropriate ventilation and your doors are sealed, secondhand smoke can only be reduced and not eliminated. So they've had studies where people who are non-smokers, who are neighbors, not in the same apartment as somebody else who smokes, have elevated levels of nicotine in their bloodstream. So they're not even in the same apartment, but that smoke and that nicotine is still getting into their apartment, and they have elevated levels of nicotine in their bloodstream. So smoking is not a protected right. Smoke-free housing policies, as I said, are increasing and they're lawful. And landlords recently have been held liable for failing to protect tenants who are known to be sensitive to secondhand smoke. So it's a really important issue. Oops. Sorry. Okay. So I said I was going to define what a screening test is, because we're going to talk about lung cancer screening with CT, and that's a screening test. Well, what is a screening test? It's a test that we use in a population to identify unrecognized disease in individuals without signs or symptoms. So CT screening for lung cancer is a screening test. What are some of the other common screening tests that are used in medicine? So we've used chest x-rays to screen for lung cancer in the past, but we've come to realize that chest x-rays are not really an effective tool for identifying lung cancers at an early and treatable stage. Other screening tests: mammography for detection of breast cancer, colonoscopy for detection of colon cancer, PSA, even though the recommendations for PSA testing are prostate-specific antigen to detect prostate cancer, those recommendations are sort of changing. Pap smears to detect cervical cancers, HIV and hepatitis blood tests in asymptomatic patients who may be at risk, and also routine blood glucose testing to detect for diabetes. So this is just a little schematic of what a chest x-ray is. On the left-hand side there, you'll see a gentleman who's undergoing a chest x-ray. And when the radiologist gets the chest x-ray for interpretation, what we get is a frontal chest x-ray. So here we're looking at the frontal view. This is the patient's heart. This happens to be a female patient. We can see the breasts here. And then the black parts on this image with the ribs, these white things running between it, those are the lungs. So they're filled with air, and that's why they're black. The x-rays penetrate through there quite well. And hopefully, when we're looking at a chest x-ray, we might be able to see the abnormality that we're looking for, but also show some examples where that's not always the case. And this is the lateral chest x-ray. So here's the heart on the lateral view. These white things here, these little boxes are the vertebral bodies, so that's the spine. And the dark areas that we see are the lungs. So sort of comparing and contrasting with a CT examination, this is what it looks like when a patient is getting a CT examination. They're sort of whisked through this donut-appearing machine that's round, and they're whisked through. It also uses x-rays, but instead of it being a static x-ray source like a chest x-ray, the x-rays are sort of rotating around them. It's much more technologically advanced, still relatively quick and easy for the patient. But when we get a chest CT as opposed to the chest x-ray, the images look quite different. So what we get are cross-sectional images that image the lung in their entirety. And when we see those images, right and left are reversed for the radiologist. So it's as if we're looking at the patient from their feet towards their head. And we're able to get really, really nice and fine detail on these images that allow us to see things that are just not visible on a chest x-ray. So I think I've already answered this question. So for screening for lung cancer, is chest x-ray good enough? And the answer is no. So there have been multiple studies that have shown that there's no significant mortality benefit in smokers who are screened with chest x-ray versus no screening at all. But chest x-rays aren't useless, so if you go for a chest x-ray, you shouldn't say, I don't need this because it doesn't show anything. There are certain things that a chest x-ray is quite good at showing. So here's a chest x-ray in a patient who's got abnormal fluid collecting around their right lung, and they've got some adjacent non-aerated lung because that fluid is pushing on the lung and not allowing it to expand. Here's a patient that's got an abnormal opacity here in the middle of their left lung. Probably represents a pneumonia. If the patient has a pneumonia, they can be treated with antibiotics. We can bring that patient back, do another chest x-ray, and if it resolves, then we know that we've cured the patient. Here's another patient that has a large mass in the left lung and also what looks to be some adenopathy in their mediastinum. So that's not a good thing for this patient, but something that we can see on chest x-ray. So here's an example of a chest x-ray and a CT, so just sort of comparing what we can see in the same patient on a chest x-ray versus a CT. This is the patient's right lung, this is the patient's left lung, and here's the heart. We see the ribs, the clavicles. There's a lot of things that we can see on the chest x-ray. But something that we can see on the CT scan here in the right lung that's not so easily seen on this chest x-ray is a rather large abnormal opacity in the right upper lobe, or the upper portion of the right lung, that turned out to be a lung cancer. So this is something that we can see quite easily on the CT, and maybe in retrospect we might be able to see something on the chest x-ray, but it could be easily missed, and that's not something certainly not something that you'd want to miss. Here's another example. Same patient. Ends up this patient had 2 lesions in their lungs. This is the left side. Again, I said right and left are reversed. So here's a kind of a very worrisome looking nodule or mass in the left upper lung that is really only seen kind of faintly in retrospect on this chest x-ray here between the first and the second rib. Really not easily seen, but quite dramatic on the CT, as you can tell. So there's differences in things that we can see on CT versus x-ray. So something that sort of prompted all this new talk and approval for lung cancer screening CTs in the appropriate population was something that was called the National Lung Cancer Screening Trial. So this was a big, big study, involved thousands and thousands of patients who were smokers, so patients that we knew were at increased risk for developing lung cancer. And the results of this study were published in a very respected journal called the New England Journal of Medicine back in 2011. As I said, a lot of patients, over 53,000. These patients were current or previous significant smokers, and their ages were 55 to 74. And these patients came in for screening, and they were randomized either to getting a CT or to getting a chest x-ray. And what they found after a couple of years of doing this test was that there were 20% fewer cancer-related deaths in those patients who were undergoing annual CT screening versus those who were undergoing annual chest x-ray screening. And if we reduce the mortality of lung cancer by 20%, that would be equal to curing all of lymphoma, or 2/3 of breast and colon cancers combined. So it's really a significant number of patients who can be helped by screening. So overall gist of the lung cancer screening test that was published in trial that was published in 2011 was that more cancers were found and found at an earlier and more curable stage with CT versus chest x-ray. And the results were so convincing, so compelling, that they actually stopped the trial because they felt they were putting those patients who were just getting an x-ray at an unnecessary risk by not allowing them to have the annual screening CT. It's important to remember that the results of this test only apply to those patients who were screened. So we were screening patients who were smokers, increased risk for developing lung cancer, and patients who were between 55 and 74. We weren't screening younger patients, we weren't screening older patients. So sort of as a result of this study that was published in 2011, the U.S. Preventative Services Task Force, and this is sort of an independent panel of private sector experts who are experts in prevention and primary care. In 2013, this task force recommended annual low dose just means low radiation dose, lung cancer screening CT for high-risk patients with greater than 30-pack year smoking history between the ages of 55 and 79. So they took it from that 74 limit that was studied in the trial, and they took it up to 79. As I said, this USPSTF is a leading panel of independent experts, and their recommendations influence which therapies and tests will eventually be provided by Medicare, Medicaid, and then private insurers. And it's estimated that as many as 10 million Americans will fall within these screening guidelines. So that was in 2013, so we wait a little bit we waited a little bit. There was a lot of news in the media going on. But finally, in February of 2015, so relatively recently, the Centers for Medicare and Medicaid Services announced that they would cover annual low-dose screening CT for this very same or similar patient population. So significant smoking history, current smokers or quit within the last 15 years. Their age criteria, if you look at their website, is actually 55 to 77. So they're going to reimburse for screening these patients annually with low-dose CT. They're also going to include smoking cessation and counseling and shared decision-making on the risks and benefits of low-dose lung cancer screening CT. And as a result of this CMS offering coverage for Medicare and Medicaid, a lot of private insurance companies have already followed, and many more are sure to follow as time goes on. So you've determined that you're a candidate for screening CT and you want to get screened because you want to take advantage of this benefit. So what should you expect and how do you get screened? So it's important to know that unlike some other screening tests like a colonoscopy for detection of colon cancer, there's actually no preparation. So you don't have to stop eating, you don't have to take a colon cleanser, no preparation, and you don't need an IV inserted in your arm for any dye because we're not going to administer any contrast dye for this study. It's a non-contrast exam. So a lot of you have probably heard of MRIs or had an MRI and heard the horror stories about people who are claustrophobic and they're noisy. That's just simply not the case with CT. There's not a lot of noise. The area of the machine is a lot wider than an MRI machine, so patients generally tolerate it quite well. It's extremely fast. It's generally completed just in the time that it takes that you can hold your breath. So 15, 20 seconds, hold your breath, you're zipped through the machine, and you're done. And the total time typically from check-in, even though the scan itself only takes a couple of minutes, there's check-in, you have to wait, you have to go through and then come out and get dressed, get undressed. It's about 30 to 45 minutes, so it's relatively quick. So as with any screening test, there's always drawbacks. The first thing that you might worry about is the radiation risk. But really in these studies, we're getting radiation exposures that are extremely low. We're really modifying our techniques and just using that amount of radiation that gets us a diagnostic study. And the amount of radiation that the patient receives for these low-dose studies is on the order of about 1/3 to 1/4 just annual background radiation exposure from walking around New York City or flying on a plane. So just 25 or 30% of the radiation exposure that you just get by living for a year. So it's really quite insignificant. The thing that people talk about a lot is the high false positive rate. So what's a false positive? That means that when we do this lung cancer screening CT, we find something on the CT. Doesn't always mean that it's lung cancer. It might be something that's benign. It could have been there for 20 or 30 years. Who knows? But it leads to quote unquote unnecessary follow-ups or interventions. So it's benign. We don't know it's benign, but you've got to come back for another CT. If it looks worrisome enough, you may get sent to a surgeon or somebody else for a biopsy. And these are things that are potential negatives about screening CT. So biopsies, additional imaging studies, and also you can't discount patient anxiety. So you find something on a CT, tell them you've got to come back in 3 or 6 months, or even you have to come back next year. The patient lives with that anxiety for those 3 months, 6 months, or 1 year waiting for what the next test is going to show. So that's something we can't really discount. And also cost. But this is sort of becoming less of a factor since Medicare and Medicaid and other private insurance companies are going to start reimbursing. It's no longer necessarily an out-of-pocket expense. And also a lot of centers are providing these studies for very reduced cost or even for free in some locations. So as we said, Medicare and Medicaid are covering these exams. Private insurance companies, that's sort of up in the air, but a lot of them already are covering the exams. Another consideration that might be a drawback is, what if I fall outside of the screening guidelines? What if I'm 45, but I've been smoking since I was 16, 2 packs a day? Or what if I'm 85, but I'm still healthy and I'm outside of the screening guidelines? What do you do then? Is it going to be covered? Do you pay out of pocket? So those are still sort of things that need to be worked out. So you have a screening CT. The best result would be that it's negative, we'll see you next year, because the whole goal of this program is annual screening. So even if they find nothing, you're still going to come back in 12 months for another low-dose CT. So if the radiologist finds something on your CT, a nodule, we characterize it, certain categories. That's a nodule, but it looks certainly benign. We'll see you next year. Or there's different ranges of concern up to something that's definitely malignant, in which case you may be immediately referred to a surgeon for a biopsy, or a nuclear medicine study called a PET-CT to look for malignancy throughout your body if we think that that's a malignancy in your lung. So the more worrisome the nodule that is seen on chest CT, if you have a nodule, the higher the likelihood that you're going to have a short-term follow-up or some other form of intervention. And these follow-ups, as I mentioned before, range from, at the short term, probably 3 months, to just come back next year. We see something, but we're not really worried about it, come back next year. In the past, when we weren't really talking about lung cancer screening, radiologists used something called the Fleischner Society Guidelines. So this is a group of radiology and thoracic experts who came up with these guidelines for different types of pulmonary nodules. But now that lung cancer screening has sort of come to the forefront, we're kind of developing new screening follow-up guidelines that will be used just for screening patients, sort of the same as we have guidelines for patients who are undergoing mammography. So these follow-up recommendations are sort of in flux, and those are going to be instituted at centers that are doing these low-dose screening CTs in the near future. And it's also important to remember that just because something's found on your CT and a follow-up is requested, it doesn't necessarily mean that you have lung cancer. So remember that high false positive rate. You see something, it's not necessarily cancer. You might have to have a follow-up, but it doesn't necessarily mean that you've got cancer. So what can we see on a CT that's not a lung cancer? So here's an example. I just got one example here. I could point to a number of things, but this is just kind of an interesting case here. So both of these are smokers who had screening CTs. Here's the normal patient here, and this is the abnormal patient. So we see all these little dark holes in the patient's lung, these little dark holes that the patient over here on the other side does not have. And this is what emphysema looks like to the radiologist on a CT. So despite the fact that we don't necessarily see a worrisome nodule in this patient has diffuse emphysema, presumably related to significant cigarette smoking. So how do I get screened? You meet the screening criteria, how do I get screened? So a lot of large medical centers and even private practices are offering lung cancer screening, low-dose studies. You can get information on their websites. Just do an internet search for lung cancer screening in your area. Ask your primary care doctor to be referred to a pulmonologist. That's always a good idea, so you can have shared decision-making and talk about the risks and benefits of lung cancer screening CT. As I mentioned before, if you don't have private insurance or you don't have Medicare or Medicaid, many institutions are offering reduced cost screening CTs. And as I mentioned several times before, Medicare and Medicaid are now reimbursing for these exams. So NYU, just like a lot of other large medical centers, has a screening program. Here's a little link to the website here for the NYU lung cancer screening program. And we even have an 855, which is equivalent to an 800 number, 855 NYU lung, and that'll help you get connected to the appropriate people that you need to get connected to make sure that you get an appropriate screening examination and the counseling that you need in order to do that. Thank you very much.